Good morning, respected Emeritus Chairperson Dr. M.L. Swankar sir, President cum Vice Chancellor Dr. Achal Gulati sir, Pro Vice Chancellor Dr. V.K. Kapil sir, faculty members and my dear colleagues. Today, I welcome you to 31st Postgraduate Combined Round being conducted by Department of Pediatrics on the topic Approach to Febrile Child. Myself, Dr. Agarwal, Associate Professor, Division of Pediatric Gastroenterology and Pathology, Department of Pediatrics. Now I invite Professor and Head of the Department, Dr. Rupesh Masan sir, and Professor and Unit Head, Bone Marrow Transplant Physician, Dr. Riya Choudhary ma'am, to chair the session. Fever is one of the most common reasons for which a child is brought to the medical attention, whether being the OPD, ward or ICU. Fever in a child can present with the subtle clinical signs which can be benign, self-limiting medical condition, or it can be a life-threatening situation. The fact lies in the clinical examination where signs can be subtle, misleading and non-specific. So this warrants a thorough clinical examination which should be well structured and formatted. This leads to the treatment that is not over-treated and also not under-treated if the serious condition underlies. May I now invite Dr. Ayushi Agarwal, third year postgraduate resident, to deliberate on approach to febrile child.
Good morning, everyone. My name is Dr. Ayushi Agarwal. I am third year resident from the Department of Pediatrics, and under the guidance of Dr. Rupesh Masan sir and Dr. Agarwal sir, I will be starting off today's PGCR from the basics of fever. By the end of today's session, we all shall be well versed with the definition of various aspects of the fever, including definition, measurement, types, etiopathogenesis, and the clinical approach. The normal body temperature, if measured rectally, varies from 36.6 degrees Celsius to 37.9 degrees Celsius, that is 97.9 degree Fahrenheit to 100.2 degree Fahrenheit, with a daily variation of about 0.6 degrees Celsius. The temperatures are lowest in the early morning and highest in the evening. If the core body temperature, which is measured rectally, if it is greater than 38 degrees Celsius or 100.4 degree Fahrenheit, it is labeled as fever. If the temperatures measured rectally, if they are greater than 40 degrees Celsius or 104 degree Fahrenheit, they are called as hyperpyrexia. Any fever of recent onset, that is less than 7 days of duration, with no obvious historical or physical explanation, is labeled as fever without source. And any documented fever for which no cause is identifiable after either 3 weeks of outpatient evaluation or after 1 week of inpatient evaluation is labeled as fever of unknown origin. Now, assessment of fever is a very important aspect. So, touching is a very crude and unreliable method, and the digital thermometer is the best. From birth up till 5 years of age, the rectal temperature is the most definitive method. However, axillary temperature can be used as a screening method. Beyond 5 years of age, oral method is the most definitive temperature, and axillary, tympanic or temporal artery can be used as a screening. It is important to know that the axillary temperature is about 0.5 to 0.8 degrees Celsius lower than that of the oral temperature, and oral temperature is again 0.5 degrees Celsius lower than that of the rectal temperature.
ये tympanic and temporal artery से कैसे करेंगे
सर मैं नेक्स्ट टाइम बता रही हूँ. There are various thermometers available to us. The first is the mercury thermometer, which is used for the measuring axillary or oral temperatures, but is not used nowadays due to risks of toxicity. The digital thermometer, which is again used for measuring axillary or oral temperature. The rectal thermometer is similar to that of the digital thermometer, but it has a soft bulbous tip and it reduces the risks of injury. Then we have the electronic or the tympanic thermometer, which measures the heat waves from the eardrum, and it can be used in infants 6 months or older. We have temporal artery thermometer, which measures the heat waves on the side of the forehead and can be used in infants 3 months or older. And then we have infrared thermometers, which are non-contact, rapid, non-invasive, and have poor accuracy and were used only for screening purposes and not into day-to-day life. Then coming to types of fever, we have the continuous fever. If there is a persistent rise in temperature where it does not touch the baseline with minimal daily fluctuations, it is labeled as continuous fever. It is commonly seen in pneumonia, urinary tract infections, meningitis. If there is a persistent rise in fever with daily fluctuations greater than that of 2 degrees Celsius, it is labeled as remnant fever, seen in diseases like tuberculosis, infective endocarditis. If there is a periods of normal temperatures followed by febrile phases with wide fluctuations, it is labeled as intermittent fever. They are commonly seen in abscess, malignancy, and drug fever. Codoreal fever refers when there are febrile episodes every day, seen in Plasmodium falciparum infections. Tertian fever is a fever occurs every 48 hours. They are commonly seen in Plasmodium falciparum, vivax or ovale, and quartan fever. Their fever occurs every 72 hours, seen in Plasmodium malaria infections. Then we have relapsing type of fever, where the afebrile phase between the febrile period lasts for more than 24 hours. It is commonly seen in Borrelia infections. Then we have Palepsine type of fever, where the afebrile fever lasts. It's a periodic type of fever where its periodic phase, afebrile phase lasts for a few days, followed by febrile phase. And then we have the step ladder type of pattern, where there's a continuous fever, but with each spike the temperature rises to a higher temperature, seen in typhoid infection. Now, temperature. If there is any peripheral trigger in the form of infections, immune complexes, or inflammation, there is release of cytokines like interleukin 1, interleukin 6, tissue necrosis factor alpha, which resets the thermoregulatory set point, which is controlled by the preoptic area of the anterior hypothalamus, which leads to increase in prostaglandin E2 secretion in the hypothalamus, which leads to physiological responses in the form of chills, shivering, vasoconstriction, and behavioral changes, leading to fever. There are various metabolic changes which occur with each 1 degree Celsius rise in temperature. The basal metabolic rate increases by 10 to 12.5%. The fluid requirement increases by 100 ml per meter square per day. The heart rate increases by 8 to 10 beats per minute, and there is an increased use of protein as an energy source. Now, etiology of fever is a very wide topic. So, just to narrow some of them down, we have picked up some few of the common findings which are associated with fever seen in a pediatric age group. So, if a child presents to us with cough and coryza along with fever, we can think about viral etiology. If there is presence of throat pain, difficulty in swallowing, palpable cervical nodes, then it may be pharyngeal tonsillitis. Stridor along with fever is maybe croup. Fast breathing, cough, wheezing along with fever may point us towards a diagnosis of pneumonia, bronchiolitis, or tuberculosis. Vomiting and diarrhea are commonly seen in gastroenteritis. If there is presence of increased urinary frequency, burning, maturation, hematuria along with fever, it may be a urinary tract infection. Presence of altered sensorium, seizures, meningeal signs with fever may be meningitis, encephalitis, or meningoencephalitis. Hepatosplenomegaly is again a very important clinical finding in the pediatric age group. The most common causes include some infectious causes like malaria, enteric fever, dengue. However, they may be seen in malignancies like leukemia, lymphoma. We have few rarer causes of fever also, like rheumatological diseases including juvenile idiopathic arthritis or hypersensitivity disease, or neoplasms like Hodgkin disease, pseudomocytoma or neuroblastoma. Fever is also seen in granulomatous diseases like Crohn's disease, sarcoidosis, and few familial and hereditary diseases. Now, the approach to febrile signs starts with a meticulous history taking from a reliable informant, a mother, a father, or any close relative. So, in history taking, first of all, we need to see the characteristics of the fever in the form of onset, intensity, progression, duration, and the pattern. And how was the fever assessed, whether it was done manually or by a thermometer, and what was the site of the documentation. What are any associated symptoms? Myalgia, fatigue, rashes, cough, cold, headache, if present any. If there are any aggravating or any relieving factors. And has there been any recent exposure to any insect or animal bite or any transfusion of the blood products? We also have to take into account the past history to rule out of tuberculosis, UTI or malignancies or any chronic diseases. The family history. Immunization history is very important aspect because vaccines like DPT may cause fever post-vaccinations. The medication history, the form of there has been a history of penicillin, rifampicin or phenytoin, which may cause fever in children. The socio-economic history and the travel history to rule out any endemic diseases. Now coming to an examination. The first examination starts with the general appearance of the child. We need to assess if the child is toxic looking, sick looking, irritable, inconsolable or dehydrated. We have to assess all the vitals in the form of temperature, pulse rate, respiratory rate, blood pressure and the capillary refill time. The anthropometry, weight for age is an important aspect by assessing any child with fever to rule out any chronic disease or any acute or chronic presentation. General examination in the form of pallor, icterus, clubbing, lymphadenopathy. The head-to-toe examination must include ear, nose, throat examination, joint examination, skin and genitals, and a thorough systemic examination. Now, rash is a very important clinical finding in a febrile child, which requires minimal investigation. So now I would like to invite Dr. Riya Choudhary to elaborate on that.
Thank you, Dr. Ayushi. Good morning, everyone. I'm Dr. Riya Choudhary, third-year resident from Department of Pediatrics. I'll give an overview for the topic fever with rash, which we commonly diagnose clinically on OPD basis. Rash is a very common presentation with fever seen in children. Rash can be divided into infectious and non-infectious based on their etiology. Infectious etiology usually contains viral and bacterial illnesses. Viral illnesses like measles and rubella and bacterial illnesses like scarlet fever. Non-infectious etiology usually contains drug which we commonly use like phenytoin or carbamazepines or NSAIDs even too. Autoimmune disorders like systemic lupus erythematosus and other diseases like Still's disease or Kawasaki disease can also give a presentation with rash. Now, I'd like to explain few lesions which we commonly see along with their distribution and morphological features and the most common diseases which we usually encounter. The first row shows maculopapular rash. As we can see, this is a maculopapular rash with a widespread involvement. And here we can see there are macules, there is a mixture of lesions of macules and papules. So macules are flat, red or pink spots, usually less than 1 centimeter in diameter. And papules are small, pinpoint, solid lesions, can vary in size, can be less than 1 centimeter or can be more than 1 centimeter in their diameter. The most important thing about papules is that they usually blanch on pressure. The rash has a usual appearance on the beginning on the face, then spreading to the trunk and limbs, appears usually around day 3 to 5 of fever and most commonly seen in measles, rubella, dengue or erythema infectiosum. The next lesion is vesicular rash. As we can see, these are the typical vesicular lesions, more than 1 centimeter in diameter and are usually consist of clear fluids. As we can see, there is also an erythematous base around here. So vesicles usually presents with erythema all over. So these are also classically called as dewdrop on a rose petals and they have a centripetal distribution, mostly over trunk and then face and then limbs. Usually occur from day 1 or 2 to fever, most commonly seen in chickenpox. The next one is bullous rash. It has a generalized presentation. As we can see, this is a typical lesion more than 1 centimeter in diameter and usually consists of purulent fluid. Along with this, after these bullae burst, we have a skin peeling kind of appearance too. These are usually seen in Stevens-Johnson syndrome or progressive category. The next one is pustular rash. Pustular rash is predominantly present over face or trunk, less than 1 centimeter in diameter and usually have a pus collection in them. They usually involve face and trunk and can be seen in chickenpox too. Urticarial rash is usually generalized and migratory. As we can see in this picture, there is erythema along with raised transient wheals with them. So these usually commonly involve face, trunk, flexure areas and commonly can be seen in viral infections with fever. Usually urticarial rash have a presentation without fever too, means if there is any allergy or something, but with a fever presentation, it can be commonly seen in viral infections. Petechial rash usually occurs on the dependent areas. These are pinpoint red, purple and non-blanching spots. They typically appear around day 3 to 5 of fever and these usually indicate capillary bleeding into the skin, seen in IgA vasculitis or leukemia. Purpuric rash, these are the non-blanching purple patches, indistinctive of their sizes And these usually indicate bleeding into the skin, and these are usually sudden in onset and are also progressive in nature. They have a distribution over dependent areas, and they have a typical distribution. They suggest any vascular injury, platelet disorder, or sepsis. Can be seen in atypical measles or dengue hemorrhagic fever too. Desquamative erythematous rash usually shows a diffuse redness along with peeling of the skin. First there is an erythematous rash, then comes the scaling of the skin, and then comes eventually peeling. So these usually are seen on trunk, then usually follows the palms and then soles. Commonly seen in scarlet fever to Kawasaki disease and
Patients,
so textbooks.
patients are
Just one second. The next one is nodular rash. Nodular rash are usually tend to be painful and red nodules. They are commonly present on shins but can also be present on the extensive surface of the leg. These are usually more than 1 centimeter, and these are caused by inflammatory exudation of blood and serum into the subcutaneous tissue. The most common presentation of nodular rash we see is erythema nodosum. Now, in a febrile child, except for conditions we discussed, we require help of various departments to reach a particular diagnosis. So now I invite Dr. Shikha Gupta from Department of Pathology to elaborate on pathological evaluation in the febrile child. Thank you, Dr. Riya. I am Dr. Shikha Gupta, second year pathology resident under the guidance of Dr. Manju Raghav ma'am and Dr. Arpita Mathur ma'am. In continuation of the topic approach to a febrile child, I'll be emphasizing on how basic pathology investigation help us in diagnosing even before a definitive clinical diagnosis. I'll briefly walk through hematology, urinary examination, CSF, cytology, histopathology. Before interpreting abnormalities in a febrile child, it is essential to understand that normal CBC values in children are age dependent and differ from adult values. Total leukocyte count is higher in neonates and younger children with a physiological lymphocyte predominance up to around 6 years of age. After that, gradually the neutrophils rise to adult values by adolescence. Platelet counts remain comparable to adult values through all pediatric age groups. Hemoglobin is relatively high at birth, then falls physiologically in early infancy, and then gradually rises to adult values by adolescence. Reticulocyte count is higher in early life, reflecting active erythropoiesis, and then stabilizes thereafter. Therefore, interpretation of CBC in a febrile child must always be done against age reference values to avoid overdiagnosis of leukocytosis or lymphocytosis. With this baseline in mind, I'll move to peripheral smear patterns seen in common causes of fever. This CBC shows leukocytosis driven predominantly by neutrophils. There's a significant left shift evidenced by the presence of immature granulocytes. Hemoglobin, red cell indices, and platelet counts are within normal limits. On the peripheral blood smear, toxic changes in neutrophils are seen along with myelocytes and metamyelocytes. Findings are suggestive of bacterial infection and further microbiological workup is required. Another CBC shows leukopenia with predominant lymphocytosis and monocytosis. Red cell indices, platelet counts are within normal limits. As compared to the previous smear, we can see in this smear that the WBC count is clearly reduced. In this smear, we can also see reactive lymphocytes. Reactive lymphocytes are highly suggestive of a viral infection. This CBC shows moderate anemia, reduced hemoglobin, and leukopenia. Total leukocyte count is reduced with relative lymphocytosis and monocytosis. Multiple malarial parasites can be seen in various developmental stages, including ringworms, schizons, trophozoites, gametocytes. The CBC is suggestive of a malarial infection. This CBC shows marked leukocytosis with absolute lymphocytosis, along with anemia and severe thrombocytopenia. Peripheral blood smear demonstrates blast cells. Blast cells are 2 to 3 times the size of a mature lymphocyte. They have scan to moderate cytoplasm, high ANSI ratio, open chromatin, and 1 to 2 nucleoli. These findings are highly suggestive of an acute leukemia. Now we'll discuss about erythrocyte sedimentation rate. ESR is an age-dependent inflammatory marker.
It is a non-specific but supportive marker. Its values lie in trend monitoring rather than isolated interpretation. Normal values are low in newborn, infants, and children. An elevated ESR suggests ongoing inflammation, commonly seen in bacterial infections, tuberculosis, and inflammatory conditions. It is to be noted that ESR does not exclude serious pathology, as ESR can be normal in viral infections. Coming to bone marrow examination in a febrile child, it is a selective, not routine procedure reserved for situations where peripheral blood findings raise a concern. Bone marrow biopsy is indicated in a febrile child with persistent fever or unexplained cytopenias or presence of some abnormal cells on the blood smear. Aspiration gives morphological details, while biopsy gives architecture and extent of involvement. Thus, it is important to always have a complete bone marrow examination, which includes bone marrow aspiration and bone marrow biopsy. In this case, marrow aspiration and biopsy show a hypercellular marrow in which the complete marrow is replaced by blast cells. In the inset, we can see that blast cells are replacing the marrow. These findings are suggestive of acute lymphoblastic leukemia. Urine examination. It is a simple, routine, yet extremely informative test in a febrile child. On urine examination of a child with urinary tract infection, the sample is cloudy with foul odor. The urine is often alkaline with mild protein positivity. Chemical analysis shows positive nitrite. Nitrite positivity is suggestive of gram-negative organisms like E. coli. Leukoesterase can also be positive, which indicates towards active inflammation. Microscopy done on the sediment of a centrifuged urine sample shows WBCs, sometimes RBCs, and bacteria. Pyuria with bacteriuria are hallmark features of urinary tract infection. An important pitfall is sterile pyuria, commonly due to prior antibiotics, genitourinary tuberculosis, or non-infectious inflammatory conditions. We also receive cerebrospinal fluid samples in our routine practice. Normal CSF leukocyte count decreases with age and should be interpreted using age-specific reference ranges. Normal CSF counts are higher in neonates than in infants and children, and the differential is usually lymphocyte predominant with few or no neutrophils. In bacterial meningitis, the CSF count is very high with neutrophil predominance. In viral, fungal, and tubercular meningitis, the cell count is lower or variable with lymphocyte predominant. It is to be noted that CSF samples should be processed within 2 hours of collection. So it is important to send the sample as soon as possible to the laboratory so that we can start processing within 1 hour of sample collection. In a febrile child presenting with lymphadenopathy, FNAC can be used as a diagnostic modality. In the first image, we can see there is a cellular smear composed of epithelioid histiocytes arranged in clusters along with numerous lymphocytes. In the inset, we can also see caseous necrosis. These features are suggestive of chronic necrotizing granulomatous inflammation. On ZN stain, acid-fast bacilli are identified on the smear microscopy. The presence of granulomatous inflammation along with acid-fast bacilli is suggestive of tubercular lymphadenitis. Histopathology provides definitive tissue diagnosis in a febrile child when lymphadenopathy or organ involvement is present. Here, in the first image, we can see central caseous necrosis surrounded by epithelioid histiocytes, lymphocytes, and multinucleated giant cells. Features are consistent with necrotizing granulomatous inflammation and in an appropriate clinical setting are suggestive of tuberculosis. In the second image, it shows preserved nodal architecture with hyperplastic follicles, intact mental zones, and predominant germinal centers. These findings are consistent with reactive lymphadenitis. In this slide shows effacement of architecture of the lymph node, and the next slide shows presence of Reed-Sternberg cells and lymphocytes in the background of reactive lymphocytes. These findings are suggestive of classical Hodgkin lymphoma. Thus, histopathology helps distinguish infection, reactive conditions, or malignancy, which often present with overlapping clinical features of fever. Thank you. Now I'd like to invite Dr. Kapil to deliberate on the topic Microbiological Evaluation of a Febrile Child.
So our objectives or methods in microbiology are microscopy examination, culture, rapid diagnostic tests, and molecular tests. So first, microscopic examination. First picture is of arm staining, which differentiate between bacteria from gram-positive to gram-negative. Black arrow shows gram-positive foci and red arrow shows gram-negative baselines. It guides in empirical treatment. Second picture is of gene initial staining of sputum, in which red arrow shows gram acid-fast bacilli, which are suggestive of Mycobacterium tuberculosis. Third picture is of Albert staining, in which red arrow shows dark blue metachromatic granules at the end of green bacilli, which are suggestive of Corynebacterium difficile. Now culture, some important points to remember before collecting blood for culture. Collect blood culture before initiating antimicrobial therapy or immediately before the neck growth and prior to any change or escalation of antibiotics. Adequate volume is critical, 8 to 10 ml for adults, 1 to 3 ml for neonates, 3 to 5 ml for older children per bottle. Send 2 sets of blood culture from separate clinical culture site. Transport all specimens to the laboratory as soon as possible in properly labeled leak-proof containers, maintaining appropriate temperature and biosafety precautions. And please send duly filled test requisition form. This is a flowchart of proceeding of the received samples. We incubate BD Bacterium Bactec FX 40 instrument. When flagged positive, the gram staining was performed and identified organism is promptly communicated as a critical alert in respective wards and ICUs. Then sample inoculated on culture media plates, identification in antimicrobial susceptibility done by Vitec 2 compact system, and culture report with identification and antimicrobial susceptibility test dispatched within 72 hours. If it flagged negative, a provisional report dispatched in 48 hours followed by a final report in 5 days, stating that no growth obtained on culture after 5 days of incubation. For detection of Mycobacterium tuberculosis complex, sample inoculated on Loiston-Jensen media and mini midget, which is Mycobacterium growth indicator tube. If growth observed, it is confirmed by Gill-Nielsen staining for acid-fast bacilli and reported accordingly. If no growth, report is dispatched for LJ media at 8 weeks or for mini visit in 6 weeks. Rapid diagnostic tests are mainly based on immunochromatography assay, enzyme-linked immunosorbent assay, and latest agglutination tests. These are some most common tests. For dengue fever, NS1 antigen can be detected as early as first day of onset of illness, up to 7 days. IgM antibodies for dengue fever, chikungunya, strep typhus, measles, rubella can be identified by enzyme-linked immunosorbent assay in serum. We can do latest agglutination test, which is a qualitative test to detect cryptococcal antigen in serum or CSF for cryptococcal meningitis. Malaria rapid diagnostic test is an immunochromatography test in which we detect histidine-rich protein 2 antigen, which is specific for Plasmodium falciparum, and lactase dehydrogenase, which is Plasmodium species other than Plasmodium falciparum. This is a malaria rapid diagnostic test which is positive for Plasmodium vivax. Other immunochromatography assays are hepatitis B, hepatitis C immunodeficiency virus. We can detect IgM, IgG antibodies of typhoid, of Salmonella typhi and typhoid dot for typhoid fever. Now molecular tests detect pathogen-specific nucleic acid at high sensitivity and specificity to ensure early and accurate diagnosis. These are some panels available in molecular lab: bacteria pneumonia panel, tropical fever panel, which detect dengue, chikungunya, Zika, Salmonella, Rickettsia, Plasmodium, Leptospira vaccinale, CBNAT, which is cartridge-based nucleic acid amplification test, which detect Mycobacterium tuberculosis and rifamycin resistance, influenza panel, bacterial meningitis panel, encephalitis panels. There are 3 biofire film array panels recently added in molecular lab: pneumonia panel, which identified 33 clinically relevant targets from sputum, endotracheal aspirate, bronchoalveolar lavage, in which 15 of the bacteria of the biofire pneumonia panel provide semi-quantitative results, which may help determine whether an organism is a colonizer or a pathogen.
Biofire is started in our institute.
3 panels, sir. Pneumonia, meningitis, and bacterial culture identification. उसमें positive blood culture की bottom से identify.
सारे departments confirm किया है.
So, हाँ sir.
ये रखा है ना? Well, last time I told you to confirm all the departments.
In meningitis panel test for a comprehensive set of 14 bacteria, viruses, and yeast. last blood culture identification panel, which detect 43 targets associated with bloodstream infection, including gram-negative bacteria, gram-positive bacteria, fungal pathogens, and 10 antimicrobial resistance genes. All with one test and with results available in about an hour from positive blood cultures. Quickly identifying the cause of bloodstream infection and sepsis may help clinicians more rapidly and appropriate management. Thank you. May I now invite Dr. Shivani for deliberate on with biochemical.
Thank you, Dr. Kapil. Good morning. I am Dr. Shivani, third year junior resident, Department of Biochemistry, covering the biochemical evaluation of febrile gel. I will be covering the diagnostic approach of the febrile gel, comparison of various inflammatory markers, and body fluid analysis. Then we have the diagnostic approach to the febrile child. We receive the patient in the OPD with febrile illness. Generally start with the baseline investigation, starting with the liver function test, kidney function test, electrolyte, serum electrolyte levels, and glucose. In liver function test, we generally assess the excretory functions of the liver, in which we are doing the bilirubin, total bilirubin direct and indirect, in which we assess the liver circulation and there is any blockage or excretory function of the liver. Then we assess the transaminases activities. We have alanine transaminases and aspartate transaminase activity, which is generally high in the viral infections like hepatitis. Then we assess the synthetic functions of the liver, in which we are generally assess the hypoalbuminemia, which is basically seen in the chronic inflammatory conditions. Then we have the certain inflammatory markers, which is acute phase reactant, starting with the CRP, which is synthesized by the liver and mediated by the interleukin 6. Early rises 6 to 8 hours after the bacterial infections, and decline compared to the procalcitonin slowly. And then we have the procalcitonin, which is specific than the CRP level, which is basically for the bacterial sepsis. And the declining phase of procalcitonin help in the guidance of the antibiotic stewardship. Then we have the organ dysfunction assessment, in which we assess the same it is also acute phase reactant, negative phase reactants, basically high in the hyperinflammatory conditions, that is rheumatoid arthritis, lupus, and in the pediatric age groups. Disease-specific evaluations and monitoring and prognosis with the help of CRP and procalcitonin. Then we have the sepsis biochemistry study. Then if we suspect the sepsis in the febrile child, starting with the procalcitonin level, combining with the lactate level, which is a tissue perfusion markers, which identify the low oxygen carrying capacity to the tissue, which leads to tissue hypoxia. After that, we assess the organ dysfunction by ordering the kidney function test, liver function test, and electrolyte levels. Then we have the comparison with the inflammatory marker. We have procalcitonin, generally primarily with the bacterial sepsis, highly specific, early rise, and rapid decline. With the CRP, same as inflammation, low specificity comparative to the PCT, early rise, and comparative to the PCT, the decline is slow. Then we have the interleukin 6, early inflammatory responses and cytochrome storms, high sensitivity, very rapid rise, and peak up to 4 hours. Lactate level also up defeated, as we already discussed, tissue perfusion markers generally assess the metabolic dysfunctions in the body. It is a real-time monitoring by place a patch. We assess the lactate level in the sweat and peritoneal fluids. Then we have the body fluid analysis. Cerebrospinal fluid analysis, we assess the glucose in our lab, glucose and protein. In viral infection, glucose level generally high, but in bacterial and tuberculosis, which will be comparative to the normal, low. Protein in viral infections, which is normal, and in the bacterial and tuberculosis,
comparative to the normal, elevated. Then we have the ascitic fluid testing, in which we assess the LDH level for malignant infusions. Glucose decreases in TB peritonitis, amylase and lipase for any pancreatic fluid in the peritoneal cavity. Then we have the certain tumor marker assessment in the ascitic fluids. Then AD increase in the TB peritonitis. Then we have the creatinine level. Is there any urine leak in the peritoneum after the any gynecologic procedures? Then we have the bilirubin level in the ascitic fluid. We assess the bile leak into the peritoneum. Then we assess the serum ascitic fluid albumin gradient, which generally assess the oncotic pressure gradient between the vesicular and the peritoneal cavity. High SAC indicates the high hydrostatic pressure, and low SAC indicates the increased permeabilities and low oncotic pressures. This is the common causes of high SAC, which is liver cirrhosis, congestive heart failures, Budd-Chiari syndromes, portal vein thrombosis. For low SAC, tubercular peritonitis, malignancy-related ascites, pancreatic ascites, and nephrotic syndrome. Then I will be calling the Dr. Sanjay to deliberate the radiological evaluation of the febrile.
Sanjay Paliwal, second year junior resident, Department of Radiodiagnosis, under the guidance of Dr. Kumar sir and the Dr. Jay Choudhary. I would like to discuss over this common clinical conditions seen in pediatric patients. Maxillary sinusitis. Child usually present with fever, facial pain, cheek tenderness, and nasal discharge. In skull photos view, we can see there is a mucosal thickening with a fluid level seen in right maxillary sinus, whereas the left maxillary sinus and the bilateral frontal sinuses are normal. So it is a case of right maxillary sinusitis. Epiglottitis. This radiograph.
Can I just go back for one second? This is not coming to this. You said maxillary sinus. We are dealing with kids over here. What age would the maxillary sinus be developed on the
So maxillary sinus is usually the first sinus to develop in children, so, and it is present by
Is it the first sinus?
usually.
Okay, let's go further. It's not. Let's go further. What do you think is the age of this person? This X-ray. It's an adult X-ray. Because the aeration occurs till the age of 18 in a child, and this is one of the most unreliable sources for taking the infection or not. Especially in children, they are unaerated. They are basically very primitive sinuses over here because of the unaeration, and it's not possible to read the X-rays. This is an adult X-ray. So what Dr. Shwanta said in the beginning, try to get your own X-rays and take pictures. You have enough of clinical material. All of us have phones with us. Let's keep on taking the photographs as and when they come. So the very good phones are there. So let's develop our own lab. And this would not be a very common feature in children. If you're looking at in children, then we would like to look at ethmoids as a possible source of infection for people, not maxillary sinus. Maxillary sinus would not be commonly present in children.
Epiglottitis. This radiograph is taken from 4-year-old child who present with high-grade fever, sore throat, difficulty in swallowing, and drooling of saliva. In later radiograph of neck, we can see there is a thumb sign, which occurred seen due to the thickening of epiglottitis. Acute laryngotrachobronchitis, which is also known as croup cough. The child usually present with fever, protrated cough, difficulty in breathing, and inspiratory striking. On EP radiograph of neck, we can see there is a staple sign, which occurred due to the edema and inflammation of subglottic area, which result in tapering of upper part of trachea, which is lead to the staple sign. In retropharyngeal abscess, the child present with fever, neck pain, difficulty and pain during swallowing, and the drooling of saliva. On lateral cervical spine radiograph, we can see there is a prevertebral soft tissue swelling, which is more than half EP diameter of adjacent vertebra.
It's more important in this X-ray to take when you're looking at the prevertebral shadow. The straightening of the spine is due to the spasm of the muscle, that is more indicated. Okay.
In bronchiolitis, this radiograph is taken from 1-year-old child who presented with low-grade fever, tachypnea, and wheezing. This is a AP chest radiograph in which we can see there is a bilateral hyperinflated lung field with flattening of diaphragm is seen. In pneumonia, the child usually presents with high-grade fever, cough, difficulty in breathing, and tachypnea. This is a PA chest radiograph in which we can see there is an inhomogeneous opacity seen in left lower lung zone, which is obscured in the left cardiac with air bronchogram. In round pneumonia, these radiographs are taken from a pediatric patient which have a history of 10-day history of fever, cough, and reduced oxygen saturation. In this AP chest radiograph, we can see.
ज़्यादातर AP views कर लिए
Yes, sir.
जो आप X-rays दिखा रहे हो except one X-ray
Yes.
you're showing all AP chest radiographs. Why it is any specific reason which you can
In pediatric patients, X-rays are usually done in EP because
child is
more
lying down on the
lying
bed.
down on
So simply. Otherwise, preferred view is
PA.
why?
So in that the lung field will be more clearly visualized.
Heart का क्या होगा?
So, in AP is usually the visceromegalies.
इसकी एज क्या है पेशेंट
Yes, a humorous classification is not. In this AP chest radiograph, we can see there is a well-defined homogeneous opacity seen in right middle lung zone, which is completely resolved after the treatment. The round pneumonia is commonly seen in pediatric patients due to underdeveloped pore of bones and the absence of canal of Langerhans.
कोविड में कौन सी पिक्चर आती थी एक्सरे?
Normally,
सिंपल जो बड़ी फेमस थी कि ये अपीयरेंस है चार्ट सिटी पे
such as ground glass.
एक्सरे ठीक
In tuberculosis, the child present with low-grade fever with evening rise in temperature, cough which is present for more than 2 weeks, breathlessness, and the night sweat. This is the AP chest radiograph in which we can see there is a consolidation with cavitation seen in right upper lung zone and the left middle lung zone, and there is a dense nodular opacity seen in right lower lung zone. Along with that, there is a left hilar lymphedema.
If you are suspecting tuberculosis, which portion of lung or which lobe of lung you must see very carefully.
So normally, sir, initially the apical lesions are common.
Why?
So the
Right? But tell me the reason. ये बेटा एयर लविंग बैक्टीरिया होता है ऑक्सीजन चाहिए
Yes, sir.
ठीक है ना तो एपिकल लोब में एक तो
common.
वेरिएशन अच्छा होता है दूसरा क्या उसकी ब्लड सप्लाई कम होती है लिम्फेटिक ड्रेनेज कम होता है वहाँ पे उनको प्रोलिफरेशन का चांस मिल जाता है दैट इज व्हाई यू सी कैविटी एंड ऑल दोस थिंग्स इन द एपिकल रीजन ऑफ द लंग इन कॉन्ट्रास्ट टू अदर्स ऑफ कोर्स इट विल स्टार्ट फ्रॉम द बेसल बट वी विल फाइंड प्लेस इन द एपिकल बिकॉज ऑफ द better aeration, decreased blood and lymphatic flow in the apical region, which leads to the proliferation of these bacteria, microbial tuberculosis, as well as for their mutation. Right?
This is a AP chest radiograph in which we can see there is a bone focus seen in right lower lung zone. It is an ill-defined faint opacity seen in right lower lung zone, which is obscured by the red cell. And this is the axial non-contrast CT image of chest in which we can see there is a calcified bone focus which is known as Frankie's complex. In miliary tuberculosis, the AP chest radiograph, we can see there is a multiple tiny diffuse nodular opacities are seen in bilateral lung. Pyogenic liver abscess, the child usually present with fever, right upper quadrant pain, vomiting, and the poor feeding. On ultrasonography, we can see there is an ill-defined heterogeneous, predominantly hypoechoic lesion with internal echoes and posterior acoustic enhancement is seen in right lobe of liver, which is suggestive of liver abscess. On axial contrast in a CT of whole abdomen, we can see there is a well-defined hypodense lesion with central necrosis with thick peripheral enhancement, which is hyperdense, and with surrounding edema, which is hypodense in nature. It is double targets. In appendicitis, the child usually present with fever, right lower quadrant pain, nausea, and vomiting. On ultrasonography, we can see there is a blind tubular, which is non-compressible structure, which is measuring more than 6 mm in diameter, is noted in right iliac fossa. The appendiceal wall is thickened and hypoechoic. On color Doppler, we can see there is increased mural vascularity. with mesenteric echogenicity. So it is suggestive of inflammation. Thank you. Now I would like to invite Dr. Riya to further talk on the medicine.
Which form of appendix do you miss?
So that was
Lateral elastic that you are not ruled out. It is not clear, it is not ruled out at this time.
objects, the CTs and this.
Thank you, Dr. Sanjay. Now I'd like to continue about the treatment in a febrile child. Now, the management of fever in children begins with initial assessment and stabilization. The priority for us is to evaluate airway, breathing, circulation, level of consciousness, and to look immediately for any life-threatening issues. So first we go for is to control the temperature by giving paracetamol or even considering hydrotherapy. The next we have to look also for we have to also manage life-threatening issues like shock, dehydration, seizures, respiratory distress as well. Now, once the child is stabilized, we have to identify and treat the underlying cause, which may be viral or bacterial in origin. In selected cases, especially when serious bacterial infection is suspected, we should consider giving first dose of antibiotic, especially in particularly in suspected meningitis or pneumonia. Now, the first line antibiotic is paracetamol, which usually acts through central inhibition of cyclooxygenase, producing its own antibiotic effect. The doses which we usually prefer are oral 10 to 15 mg per kg per dose, IV 10 mg per kg per dose, and rectal being 20 mg per kg per dose. Doses can be repeated 4 to 6 hourly, not exceeding the maximum dose of 60 mg per kg per day. Now, as per IAP, the paracetamol usually works by reducing the body temperature by 1 to 2 degrees Celsius within about 2 hours of administration. Other antibiotics like ibuprofen and mefenamic acids are also used, but as per Indian Academy of Pediatrics, paracetamol is the drug of choice. Now, hydrotherapy is considered if the temperature goes beyond 100.4 degree Fahrenheit. Hydrotherapy should be done appropriately using tepid sponging with water at 28 to 30 degrees Celsius. Cold water or ice should be avoided as it induces shivering, which increases the metabolic demand and can lead to a rebound rise in a temperature. Tepid sponging usually provides symptomatic relief by reducing the core temperature through evaporation and conduction. The key areas usually targeted are forehead, axilla, and groin, and the duration usually lasts till 15 to 20 minutes. Now, we have to also consider parenting counseling as well, because discomfort manifests as a change in behavior of a children, and parents usually tend to get anxious when the child presents with fever. Antipyretic should be given at the peak of fever, and antipyretic, we have to explain them that antipyretic doesn't prevents the fever, but it doesn't treat the cause. So we have to use paracetamol and avoid acids for their risk. Maintain adequate hydration, and we have to keep the child in comfortable clothing and environment.
What about aspirin?
Sir, aspirin can cause Rash syndrome, so we have to keep a watch.
Very important. Yeah?
Yes, sir.
Aspirin sometimes causes the Rash
Rash
syndrome.
syndrome.
So has to be avoided.
It has to.
So what level of fever do you think paracetamol should be at?
So, at the fever of above 99.5, 38, so with the fever. So with the fever of above 99.5, we can consider giving paracetamol.
So is it fever is a beneficial thing to the all disease or harmful?
No, so it is a beneficial thing because it has its own way to show that the body is itself fighting the inflammation.
What are the three ways in which fever help the defense of the body in a beneficial way?
So
Fever is a defense mechanism. Is it true?
Yes, yes.
तो कौन कौन से वो माइक्रो लेवल पे कारण हैं जो इम्पोर्टेंट हैं? तो फीवर आने से क्या क्या होता है? Give me 3 reasons. What happens to lymphocytes?
So they usually gather to cause the inflammation.
They secrete the things which leads to the macrophages बढ़ जाते हैं, ठीक है ना? And the growth of bacteria stops because of the life. It is a defense mechanism. Am I correct?
But fever is on account of the organism in the body or the body's response to the organism.
So body's response to the organism.
So what is beneficial then? Isn't it? Body's response. So if you are going to bring down the temperature significantly with a very aggressive manner, you are indicating to the body that ठीक हो रहा है. So the response is not.
So primarily, the role of fever is to limit the infection, to bring in because it induces the movement of the cells, the monocytes, the lymphocytes, and all the defense mechanisms. They come into play at the point where there is an infection, so as to limit it out. One thing. Most importantly, antipyretic is indicated to reduce the discomfort of the child. It is not to reduce the fever per se, which is actually a defense mechanism in response to the tissue damage that has occurred in response to the infection.
Now the question arises when to give antibiotics. So the antibiotics is usually given in all neonates, young infants with toxic look, after 2 to 3 days of fever with no improvement, and if the child is done in interfebrile phase. Now there are some common diseases which we usually see in our pediatric setting. So the antibiotics are given accordingly. The first one is common cold coryza, being a positive of rhinoviral. In age group less than 3 months of age, particularly there is no role of antimicrobials, only supportive treatment is indicated. For influenza, we give oseltamivir with the above mentioned doses. For bacterial pneumonia in age group less than 3 months, keeping in view of gram-negative bacilli predominance, we usually consider cefotaxime and gentamicin or amikacin or ceftriaxone in an IPD basis.
Gentamicin you can give in children, infants. The risk of
Sir,
ototoxicity.
sir, up to 10 days only. The first 10 days only. Beyond that, we have to think why the indication of giving an aminoglycoside. But yes, we can give if there is sensitivity.
You are writing first line. Is it okay?
So, yes, it can be given, sir.
It can be given or it should be avoided.
Sir, as per Indian Academy of Pediatrics guideline, this is recommended as the first line. And
In age group more than 3 months, keeping in view the most common agent being Streptococcus pneumonia, we usually consider amoxicillin or oral azithromycin. And if the patient needs hospitalization, ampicillin can be given. In Staph aureus, ceftriaxone plus cloxacillin can be given. In urinary tract infection in all age groups, uncomplicated is treated with oral cefixime, and complicated, if needs hospitalization, ceftriaxone can be given. Now, gastroenteritis and enteric fever, most of the time the cause is usually viral, and it does not mandate any antibiotics. However, if the progresses to dysentery, cefixime can be given, and for hospitalization, IV ceftriaxone is usually preferred. Now for meningitis in all neonates, first line is ampicillin plus gentamicin, second is ampicillin plus cefotaxime. If Streptococcus pneumonia meningitis, we can also add vancomycin to the treatment. 1 to 3 months of age group, ceftriaxone is usually preferred, and in Streptococcus pneumonia, we can add vancomycin, and the doses are adjusted as per gestational age and weight. May I now invite Dr. Gaurav Agarwal sir to sum up the approach on a febrile child.
thank you, Dr. Riya. Now to summarize, first of all, we need to do the age stratification in pediatric age group. First of all, there are neonates, that is 29 days, less than 29 days, young infants from 29 days to 90 days, and more than 3 months, that is more than 90 days. Now the basis for this classification is as neonates are in the most vulnerable age, and young infants, there is variation in practice depending on the different guidelines. And it requires blood and urine culture as a mandate. Then, more than 3 months, the vaccination impact allows for selective evaluation, and risk of UTI decreases after the age of 3 months, as there starts to be complete evacuation of urinary bladder. Before that, complete evacuation is usually not there, and stasis of urine occurs. So coming to neonates, all the neonates with fever must be hospitalized, evaluated, and started on parenteral antibiotics. Laboratory evaluation must include complete blood culture.
ट्रैफिक लाइट सिस्टम भी तो है red flags and
Yes, sir. There is traffic light system guideline. According to that, there is green light, amber light, and red light, and then classification depending on the physical examination and lab reports. So according to that, we classify and then we start antibiotics and admission.
the written units must be
Yes, sir. All the units with fever, irrespective of the
I'm
degree.
saying it is red light area.
Yes, yes. Urine analysis, C-reactive protein, procalcitonin, chest radiograph, the culture of blood and urine, and examination of cerebrospinal fluid for cells, protein, glucose, and calcium. Now coming to infants from 29 days.
Sorry, so are you trying to say that every neonate lesson must have a CSF examination if presenting with fever? But you said CSF.
Yes, sir. This is
Even if there are no signs of meningitis, you have to do a function because it's an invasive procedure. Is it a routine in all?
yes, sir.
Yes.
Yes, sir.
Yes. Sir, in fact, in neonates, they are prone to fever, most of the circumstances, and it is the presentation of the sepsis in form of lethargy, refusal to feed. There is a poor localization. So we have to investigate the neonate intro.
Just a bit of word about this, neonate. There is an entity called as dehydration fever and environmental fever as well. As the babies are not the same as us adults, they do vary their temperatures according to the level of clothing and all. So if that is the case, that is very clearly evident by dehydration, which is weight loss, as well as if you do the RFT and all, and the baby is looking well, then the CSF can be avoided in such a situation. Otherwise, I agree that that is.
Infants 29 days to 3 months. We classify whether it is well child or ill appearing child. In well child, if there is obvious focus, investigations and management as per the focus. If there is no focus, we go for the urine microscopy. We consider complete blood count, C-reactive protein, procalcitonin, and warfarin. So, if remains well and investigations are normal, then we follow up for 12 to 24 hours. Whereas in ill appearing child, if there is obvious focus, again investigations and management as per focus, and CBC, CRP, procalcitonin, urine microscopy and culture, lumbar puncture, if not contraindicated, admissions, and then empirical antibiotics can be received with culture reports. So, in children, coming to last, that children more than 3 months, again if it is well child, we go for the obvious focus, investigations as per the focus. No focus, then we see durations. If fever is less than 24 hours or more than 24 hours, if it is less than 24 hours, consider no obvious investigations, usually not required. If it is more than 24 hours, we go for urinary tract infection, and if it remains well, investigations are normal, we follow for 20 to 24 hours. Again, in ill appearing child, obvious focus, investigations as per focus, and no obvious focus, we go for CBC, CRP, procalcitonin, urine microscopy, lumbar puncture if required or not required, depending on the clinical condition, chest X-ray if required or not. Now we come to the
Is it lumbar puncture or fontanel?
sir, lumbar puncture.
You don't know from the.
Yeah, ventricular tabs, which is done for ventriculitis occasionally.
Meningitis, the fontanel CSF will not show the same findings.
Fever is
More dangerous.
So the take-home message is fever is a physiological adaptive response. Fever with rash often provides diagnostic survey to diagnostic use by timing and morphology. So most of the time, in cases of rash, investigations not required. Fever needs to be investigated, keeping in view its duration and associated clinical features. And at the last, treat the child, not the thermometer, remains always the guiding principle. So, the Department of Pediatrics conveys its sincere regards to Emeritus Chairperson, Vice Chancellor Sir, Pro Vice Chancellor Sir, Principal and Controller, PGCR Review Committee and Core Committees, Department of Pathology, Microbiology, Biochemistry and Radiodiagnosis.